So thank you to BYOS and Dr. Ashraful Haq for this wonderful opportunity. I've been given the topic DSEK, that is Descemet stripping endothelial keratoplasty, and I'll be discussing some simple and challenging cases, and this talk is intended for young cornea surgeons and residents. So as you all know, we have different types of keratoplasty: the full thickness, that is the penetrating; anterior lamellar keratoplasty, that is DALK; and then you have the posterior lamellar keratoplasty, that is DSEK, DMEK and PDEK. So the difference between DSEK and DMEK is that in DSEK you have part of the posterior stroma, you have the Descemet membrane and the endothelium, but for DMEK you have the Descemet membrane and the endothelium which is transplanted. So endothelial keratoplasty has got a couple of advantages. So it has faster visual rehabilitation, lesser astigmatism is induced with it because you use less sutures, and you do surgery in a structurally intact globe. The common indications are Fuchs endothelial dystrophy, bullous keratopathy, and this is generally a consequence of traumatic or complicated cataract surgery. So what are the instruments required for it? You require an artificial anterior chamber. The one is on the left is the plastic one from Catena, which I generally prefer. The metallic ones are also available, which are autoclavable. So this is how it goes. So this BSS is put over here on this bottom assembly. You can put a drop of visco also, and then this corneal button is pushed in place. The lower tissue retainer is lowered, and then the locking ring is again lowered, and then you screw it in position. So you need some blade and dissectors. I prefer to do manual dissect. You can also prepare it with the help of a microkeratome, but I prefer to do use manual method, and I generally plan for ultra thin dissect, which is between 50 to 100 microns. So you need your lamellar dissectors, around 350 or 400 or 450 micron blade, and then you need these lamellar dissectors. These are the disposable ones. You also have the titanium ones which you can use. You need your Teflon block and you need your trephine. Generally the sizes of trephine that you use are 8 or 7.75 millimeters or 7.5, very rarely 7 millimeters. You need a reverse Sinskey hook. This is done to strip the Descemet membrane. You may or may not use a DSEK marker. Alternately, you can use a trephine and just mark the area where you want to strip the DM. A donor cornea is definitely required, and for a DSEK actually you aim for somewhere between 50 to 150. My target is 50 to 100. That is, I aim for a ultra thin DSEK, and these cornea should have ideally 3 to 4 mm of scleral ring. Now you can get the tissues in MK media or Cornisol. Cornisol has an advantage that it stays for 14 days, so you can use the tissue a little bit longer. However, the thickness is slightly thinner in there. So let's go to the donor cornea preparation. This is mounted on the Catena artificial anterior chamber, and I made an entry with a guarded knife. This is a 400 micron knife. Now for the purpose of this demonstration, I marked over here. Using a crescent knife, I go inside the cornea, create a tunnel, and then I use my 2 lamellar dissectors. Now these are the first one is slightly shorter, and you see the movement I'm moving, the way I'm moving this, left and right, and you dissect till about half or slightly more than half of the cornea. And then you change your lamellar dissector, and you can lift the anterior chamber, artificial anterior chamber, with your hand, and dissection is done 360 degree. It's a fairly simple process, takes hardly 2 minutes, and then you take it out and you put it back into your Cornisol. So if you have an inadequate scleral rim, you can have failure to get watertight, or you can have a tight chamber. So in case of an inadequate scleral rim, you cannot use the tissue, and if it's not watertight, it will result in incomplete dissection or irregular or a too thick graft. In case of a tight chamber, you can have a buttonhole or a perforation or a too thin graft, which is not recommended for beginners. As an experienced surgeon, I have managed about 20, 30, 40 micron grafts also. But what you need for beginners is you need a slight dimple, and that's when you'll get that 50 to 100 micron thing. So let's look at a basic case. So this is a case of pseudophakic bullous keratopathy, and using a 50 number blade, you can use a bud also. I've removed the epithelium for clear visibility. I like to do an inferior PI. Now this is done so that I can leave a full air bubble. I've made a tunnel already and 2 side port incisions, and then I am stripping the Descemet's membrane. So it comes out very easily. You can see it's not a difficult surgery at all. Took it out. As beginners, you can check whether you've got the whole thing or not. And I've refined 8 millimeters over here. So I use the push technique where I've just put it in using a 26 gauge needle, and this is bent in the form of a swan's neck, and I'll put a full air bubble. So Descemet you can actually do under heel-on for beginners. You can also do under air. Experienced surgeons can do under in the presence of an artificial anterior chamber or using an irrigating source from your IA cannula. So this is how this patient did, 20 by 40 at 6 months. Now let's look at some challenging cases, though this could be the result of an intraoperative complication or due to the challenging situation of the eye itself. So intraoperatively, when you're doing the donor preparation, you see, if you look at this video, it's gone too deep and it's a burst. So in such a case, there's a DM perforation, and what you can still use the tissue again. So you go to the other side, and then after you can make another incision and do another plane of dissection, and then this tissue can be used again. Now this is a case where the incision was too shallow, so you've got the buttonhole. So then you need to get a little bit innovative. I've used a cornel scissors and then dissection done on 360 degree. You also using the crescent knife to get that thing plain, and then that can be used. You always need to inspect the tissue before you put it inside the eye. So here there was an incomplete donor tissue lamellar dissection, and therefore you need to cut with the scissors. Blood is a big problem in any endothelial keratoplasty. So whatever the situation be, before putting the graft, control the bleeding. Wait for some time. You can use visco tamponade, but ideally you have to remove all the visco. So ideally you should use air. You can use, before that you can put Adaline inside the eye and stop the bleeding. Now for beginners, this can be a challenge, a very, very thin lenticule. So here you have to be very careful. Beginners can mark this also with an S stamp or an F stamp or whatever is available. You can see how much manipulation will be required in this surgery. So therefore for beginner surgeons, you should aim for slightly thicker grafts, and once you get experienced, you can go for any thickness. This was only 37 microns. Now let's look at some challenging eyes. So this is the first case is a one-eyed gentleman, young male, post AGV, BCVA of counting finger at 1 feet and IOP of 12, and he's got advanced cupping. So this picture is after the removal of the epithelium. So here in such a case, you cannot go for a scleral incision or a scleral tunnel, that what you would require, and instead you can use a clear corneal incision, and which can be later increased to 5.2. Use the microkeratome. Don't increase with the 2.8, otherwise it's because it makes it irregular. You can trim the AGV tube. It should be slightly more than what I have done. Unroll the graft, and then endolenticule is put inside the anterior chamber, and the incision is sutured. A full air bubble is put, and you can see it's very well opposed. This patient is about 20 by 30 at 1 year. However, this patient developed a bacterial corneal ulcer after 4 years of follow-up. He did not come at the time of the ulcer. He came a little bit late. This was medically managed, and then a repeat DSEK was done, Sorry for the error, it's a bacterial keratitis, not fungal keratitis as written, and this patient is also doing pretty well. Now this is a second case, a 75-year-old case with pseudophakic bullous keratopathy, vitreous in the anterior chamber and a decentered PCIL. So if you see over here, the first thing is to put this vitreous, sweep it into the anterior chamber and do it automated anterior vitrectomy. After that, I noticed that the IL is not stable and therefore decided to explant it. See, most of these cases are a result of complicated cataract surgery. So you need to fix the eye first before doing the endothelial keratoplasty. More vitrectomy was done, and here you check for the sulcus, whether there is a sulcus, and then you can put a 3-piece IL into that sulcus using a 2-hand technique over here, and then the graft is taken. Put inside the anterior chamber, unrolled, and then opposed with air. This is how this patient did, 20/40 at 3 months. This is the next case. So this is a post-trabeculectomy eye, and suddenly you see that there is increased positive pressure. The globe becomes, quite tight. Now what is happening? Is it an expulsive hemorrhage that's happening? So you need to get innovative here, or could it be, fluid in the lateral space? So here, what I did was, around 4 millimeters away, made an incision into the pars plana and did a dry vitrectomy. Decompressed the globe, made it softer, and then I could easily put my endolenticle in place. Always suture your tunnel, because you don't want, by any pressure, the graft to slide out. So this patient also did pretty well. So next case is a young male with a history of trauma in childhood to the right eye with intraocular surgery and IL implantation. He's got an advanced glaucoma, an anterior dislocated IL and corneal decompensation. So in first stage, I did the IL explantation with the automated vitrectomy and placed a 3-piece IL in the sulcus. The second stage was a trabeculectomy which was done, and third stage I planned the DSEK. So this is how this patient is doing. He is a medical representative. You can see how thin the graft is, and he is about 20/80 at 1 year. This is another case. This is a perforated ulcer for which I did a therapeutic PK. Now in such situations, you do not need to go, one-eyed lady, this one, you don't need to go and repeat a PK. You can do a DSEK instead. So I made a SICS tunnel over here. Visibility is poor, so therefore I did a can opener's capsulotomy. Got the lens out. This is hydrodissection and then rotation that I am doing using a vectis to get it out. IA was done. A 3-piece IL was then placed into the sulcus, and then the endolenticle was put. I have not stripped the DM here, so it's a non-DSEK case. So this clears up, and this is how this patient has been doing. She is about 20/200 at 6 months, doing pretty well. This is another case of a PCIL which was fixed abnormally. You can see how the haptic is through the iris into the anterior chamber. Here I decided not to touch and just did a DSEK for the decompensation, and patient is doing again pretty well. This is another case with a PBK with a broken PCIL. So the plan here was IL explantation, syneculisis, vitrectomy, an SFIL, pupilloplasty and DSEK. So after removal, this is what the IOL was. I'll just show the SFIL part over here. So all this IOL was taken out. This is a sclera fixated IOL using the MYX technique, which is the modified adaptation of Yamane and the Descemet. And we published this in the IGO and got a silver medal award for it. And then this is followed by single pass through pupilloplasty, which is described by Dr. Amar Agarwal sir. I always plan to put an IOL in my all endothelial keratoplasty cases because I don't want the graft to slip into the vitreous cavity. So this gives me an extra sense of security, and whenever the pupil is dilated, it is very important that you do pupilloplasty as I have done. It's not difficult. The graft was put here, the endolenticle was opposed, and this patient also did pretty well. This is another case, a 34-year-old lady with a history of cataract surgery done in childhood. There was blunt trauma to the eye. She presented with a dislocated PMMA eye with vitreous in the anterior chamber. So first surgery I did was I explanted the IOL, did an anterior vitrectomy, and 1 year later, when she agreed, I planned to do a DSEK with an iris claw implantation. So this is how she presented. Now she's got a very thin sclera, removed the epithelium, high myope, so decided to go with a clear corneal incision rather than a scleral tunnel over here. 2.8 incision made, clear corneal, which is expanded to 5.2. Vitrectomy was already done, so decided to put an iris claw. Now why not an SFIL over here? Because you need to cut the iris, put the IOL in place, and then again a pupilloplasty. With this fibrosis, with this situation, it gets very difficult. An iris claw is a very easy surgery to do, hardly takes any time. This was enclaved. Slightly more challenging to do iris claw in such a case, but this sticks if you've done a very good thickness enclavation. So the IOL is stable, and then comes the easy part, that is the Descemet stripping endothelial keratoplasty. So I decided to go for the 7 mm graft over here. This is punched. Always visualize under the microscope and then punch it. The graft was taken. Using the push technique, you put it in place. Opposed with the air bubble, and this is definitely sutured. You see the double ring that is forming? Now this double ring sign indicates that your graft is stromal side up. This is how this patient has been doing. She's amblyopic also. The vision isn't that great, but she's symptomatically much better. Otherwise she had a lot of watering, lot of photophobia. So that's also an advantage of an endothelial keratoplasty. Even with poor vision eyes, you need to do it so that the patients get symptomatically better. This is another case. So 23-year-old, one-eyed, post-trabeculectomy. The vision is about PL present, PR accurate, and he's dependent on others for the simplest of tasks. You see a thick fibrotic Descemet membrane or a retrocorneal membrane. You see 360 degrees central and peripheral anterior synechia. Now the question arose, what do you want to do here? Do you want to do a full thickness keratoplasty, or do you want to do something else? So in such situations, I prefer to do an ASOCT and get the situation of the cornea beforehand and understand. And I take a lot of decisions intraoperatively. That's where the manual DSEK comes in, where I can decide intraoperatively to do a DSEK or a PK. So let's look at this case. So the epithelium was removed. And you see this retrocorneal membrane. So I'm using a reverse Sinski, using a repositor to break the synechia, this membrane, and you can see it's a very thick membrane, using micro scissors, doing the membranectomy over here. So this step itself took about 20-30 minutes. And when you remove this membrane, you see how thick it is. And once this is done, you can see everything inside the anterior chamber is clearly visible. So you do a vitrectomy, and then you cut these iris tags also that are there, because they can interfere with the survival of the graft. So here I'm doing an SFIL. The needle is brought out through the corneal incision, and needle haptic complex is brought out through the sclera. Similarly, it is done on the other side as well. And then I check that the IOL is well centered, and I trim the haptics and then create a flange. This is a very easy technique to do by all anterior segment surgeons, and it is buried intrasclerally and subconjunctivally. The interface rim was attached over here. Put the graft. Now this graft is put over Helon. You don't use visco inside here. You don't use HPMC. and then the graft is unfolded with the tapping movements and you oppose it with an air bubble. So remember, when you're doing a DSEK, never use HPMC or any dispersive OVD inside the eye. When you're putting the graft particularly, you should only use cohesive OVDs, and that too, if you can avoid, that's better. So over the sclera, that is where I have put the Helon, so that it stays and it protects a little bit. So this is how this patient did. This is on day 21. Day 67, you can see the cornea is clear, the IOL is stable, the flanges are very nicely intrasclerally buried. The graft is only 57 microns in size. And the best part is the patient is independent and running. So from hand movement, he's on 20/80. So I conclude, by saying that the difficult part is in the endothelial keratoplasty or the DSEK, but the anterior chamber reconstruction and management. So special thanks to all my teachers. Thank you so much.